My name is Damien Dupuy, and I'm an interventional radiologist or interventional oncologist, and I've been doing RF ablations since 1991. How many of you were born after 1991? 1, 2, 3. Okay, so you probably haven't heard the term radio frequency. Well, radio frequency's been around a long time. So Bernard Cosman developed the first RFA device in 1950 for nerve ablation. And that is the grandfather of the inventor of high power RFA. The grandfather. Now, who was the father and what did the father develop? Does anybody know? The cool tip, the Cosman coagulator, was developed by the father. And that's Eric R. Cosman. Now the son, or the grandson, is the developer of Cambridge Interventional, and that's Eric R. Cosman Jr. And he developed this high-power RFA, and Nahum Goldberg, who spent 25 years doing RFA science, developed the algorithms of heating for this. And this is the box. So this is the most highly sophisticated delivery device for RFA in the world. And what I love about it is it gives you feedback continuously about the power that's being delivered, the impedance. It has multiple modes. You can do manual mode, you can do pulsing mode. Pulsing mode is probably the best because it basically pulses, and then when the impedance gets 20 ohms above the baseline, then it shuts off again, and it continuously does the pulsing. And what it does is it keeps pushing power into the tissue. The weaker RF electrode systems kind of fell by the wayside because they were replaced by microwave. Well, Back to the Future, Cambridge Interventional has so many more benefits than microwave. The algorithms and the user interface are much more sophisticated. Most of the microwave systems you see are kind of dumb, right? You push the button on and it goes for 10 minutes. And you have no idea what the tip temperature is because it doesn't measure it at the tip. And it can't because that's a patent infringement on Ted Ormsby's device from San Diego. And he's got a 915 underpowered device, which many people don't even know exists. That's very, very important. 370 watts is what this system can create. The last system that nobody uses anymore, in fact, Medtronic bought it when they took our Covidien, and they don't even use it, yet it's more powerful than OsteoCool, which is a 25 watt. So you went from a 200 watt that's in the closet somewhere, and you have OsteoCool, which is 25 watts. This is 370 watts. Look at the electrodes. They're light. Look at the power cords, super light, long. There's no loss of power with RF electrodes like there is with microwave. So you have to have these bulky systems with bulky cooling. Super ergonomic. You know what? You will die when you look at these under CT fluoroscopy. No artifact. We all have seen the artifact of some of these bulkier microwave systems, and that's because it's high atomic weight metal. And the more metal, the more artifact. This is the least artifact applicator in the world for RFA or microwave. So I have some goodies, and these are the various types of electrodes that Cambridge Interventional makes. And they're pretty cool, actually. Above the one, obviously the one people are using for thyroid, but they make a 2, a 3, a 4, a 17 gauge 4, and a 15 gauge 5. Amazing array of what you need to use when you're an interventional oncologist. My favorite is this one. This one is a cannula, so you can place it into the patient directly. do a biopsy, do whatever through the stylet, and then this activates it as an RF electrode. So think about the applications you could do with that. I'm just going to pass it on. That's really cool. Now you can deliver drugs, obviously. You've heard the lectures this week about direct drug delivery. Well, you can deliver the drug, you can do your ablation, and then let the immune effects of the drug take place. The thermocouple is key though. And I use the thermocouple in every single case. Now, when you're perfusing the electrode with the cooled water, you want to know exactly what's happening at the tip of the electrode. That's the business end. You shut off the pump, and then you watch the thermocouple rise and the temperature rise. We know 60 degrees Celsius is immediate cell death. You will often see this 70, 80 at the tip. You then, while you have this hot zone, can move this very delicate needle and place it somewhere else. You can see it with CT fluoro, you know exactly where it is. It's precision medicine at its best. You can sculpt the lesion, you can overlap your ablation. You can say, I don't need to do another treatment there. It's telling me it's 80 degrees Celsius at a centimeter away from where I just was. So you're using that constant feedback. We do not have that with microwave. Microwave, you either underheat or you overheat. You're rarely perfect. Let's talk about the cost. How many people here know what a microwave antenna costs? How much does it cost? He says $2,500. Any other takers? Anybody from industry? How much does your antenna cost? $2,200. Okay, well, I know there's one that charges over $3,000. That's disposable. So if you use two, you lose money on every single case. Let's talk about some cases. So here we have a patient with a solitary pulmonary nodule in the right lower lobe, kind of right next to the pleura. And people always talk about, oh, I can't treat near the pleura, I've got to use cold, okay? I've been treating against the pleura for my whole career. And how do you do it? Well, in this particular case, patient is on his side, I'm coming in posteriorly. I use a 22 gauge needle and I place it in the paraspinal soft tissues, and I put in, first of all, 1% buffered lidocaine, and then I put in 30 ml of bupivacaine. I create this huge area of no muscle activity at all in that part of the rib cage, which helps in reducing pneumothorax. I'm pushing the tumor closer to the central lung, so I'm further away from the intercostal, right, nerves, so I have less chance of damaging them. So I've done that in this case, and then I turn on the power, and I treated this patient for about 4 minutes, and you can see after the treatment, we have this beautiful ground glass halo, which indicates leakage of fluid into the capillary bed that's been damaged. To me, I'm very happy. This took less than 5 minutes. And because of all that fluid I placed there, the patient had no symptoms. I used light sedation. I start off with intravenous lorazepam, and I might give them half doses of Versed and fentanyl, 25 mics in 0.5. Here is the patient's follow-up. This is a 6-month FDG PET, and we can see the thermal scar. We can actually see the needle tract. Notice there's no pleural effusion. It's a great, great treatment. So why would you want to do cryo here? Do you think you could do a better job with cryo? Do you think you could do cryo in 4 minutes? And what is the cost of cryo? How many probes do you have to use? At least 2, right? Well, if you have high power RFA in your department, why wouldn't you use it? Because you don't know about it. Because you started your training when people had already abandoned the low power RF. It's sitting in a closet collecting dust somewhere. You should be using high power RFA because it's faster, it's cheaper, it's easier to use, no artifact. It's just a no-brainer. All right, kidney and lung are my two most common ablation parts of the human body. And here we have a typical patient who gets scanned in the ER. They've got a bunch of cysts, but they also have this solid enhancing cyst that you can see on the lateral right kidney. You know, it's not as vascular as the kidney, and typically renal cells aren't as vascular as the kidney. You might get an aggressive renal cell that's hypervascular, but most of them are less vascular than the kidney. So they're very easy to ablate with RF. If you're going to use cryo on this, I'm going to be on my third case with RF while you're still finishing your first cryo case. So in this particular patient, I put him decubitus, and I want to amputate the tumor from the cortex. So I place it right along the junction with the normal kidney. Look how easy it is to see the tip of the electrode. The tip is hyperdense because that's where the cooling channels fuse. So you always know where you are. You get about 4 millimeters of heating beyond the tip, but there's a lot of fat there. That energy isn't going to go anywhere. So we treated this patient. What I always do is I look at the parameters and I say, okay, I think I cooked it completely. We had quite a few high temperature spikes. This was a 5-minute ablation, and I do the contrast study with the needle still in because it has no artifact. So I can do, and I can see the ablation zone. See the ablation zone on the cortical side? That's a great margin. But there was probably a little feeder maybe on the outside. So what do? Well, there's some residual enhancing tumor. Well, it's very simple. I pull it back a couple centimeters, I angle it, and I pop it back in. And I do another ablation. 1 minute, and you can see the changes on the lateral in the fat. 1 minute, and I got to 68 degrees Celsius. So I'm done. I've coagulated the tract, right? So I don't have to worry about bleeding. I pull the needle out, I'm done. And I tell the patient, I'll see you in 6 months. And that's what I do. I do a verification CT. If it's completely dead, I see you in 6 months. Why do I need to see you sooner unless you have symptoms? It's a waste of time. These things are slowly growing. If this is dead, it's going to be pretty much dead in 6 months, and dead forever. Here's a 3-month post. Unlike cryo though, RF, you're coagulating protein. So you denature it, so the body walls it off, okay? It's a foreign body reaction. So you may see some contraction over time, but most people will have a scar in their kidney for their entire lives. As long as it's not enhancing and it's not growing, it's not hurting anybody. Okay, here's an interesting case. I don't know if any of you went to the prostate session earlier today. They were talking about treatment of recurrent cancer of the prostate gland. And this is a gentleman who had a Gleason 7 with a PSA of 14.7 because he had bone mets, and he had radiation therapy to the primary as well as to the pelvis, and his PMSA was going up. So you can see there is a soft tissue mass anterior to the rectum, posterior to the bladder, above the seminal vesicles. The radiation oncologist says, Damien, can you treat this? And I say, well, it looks pretty good. I can probably dissect the rectum if that's a problem. So we brought the patient in, made sure that he had an enema before he got on the table, and we can see the mass is very close to the bladder. And the image on the right, you can see the doped saline that I used. Actually, I didn't use saline, D5W, to push the rectum to the opposite side. And I was able to do a biopsy and put the electrode directly in the tumor. The biopsy came back metastatic prostate adenocarcinoma. So I did 6 minutes of total heating with a Tmax of 68 degrees, and that was using non-impedance mode. I used impedance mode for 3 spikes, and then I just kind of slowly titrated the energy down. So here we have the 1 year post-PMSA, and we can see that the lesion is completely cold, and here he is on 2. So this is a great treatment for somebody who had really no other option. And it was done with RFA and some hydrodissection. Okay, what about liver tumors? Well, this is a case that came to me from the Beth Israel with a history of cirrhosis. They tried to do a biopsy and they missed the target, and the patient was all upset. So I looked at it and I said, well, why don't we come from the anterior aspect, and we can probably get our needle in there without having to worry about angling and potentially hitting the lung. So this is a lesion that had some arterial enhancement, and you can see the washout. It measured 4 centimeters. So here we have the 3 cm active tip, which was placed in the central portion of this tumor. And we did a biopsy at the same time in the middle, and then you can see the tip of the electrode very nicely. And it was a great location to treat anteriorly because it came right through the fat plane around the heart. So we did a 4-minute treatment and a 3-minute treatment for a total of 7 minutes. Now this is a 4 centimeter HCC with a maximum temperature of 78 degrees Celsius. So to me, that's dead. He came back for a contrast and non-contrast CT scan. Actually, this is the day of the procedure. And you can see the hyperdensity in the actual tract where the ablation was done. That's because of coagulated protein, not necessarily hemorrhage. And then the contrast study to the right, you can see the shell of the tumor. Patient comes back for a follow-up MRI at 9 months, and we can see the T2 dark, which is a typical post-ablation characteristic, T1 bright, due to the blood products and T1 shorting tissues. And you can see that it doesn't enhance on the arterial phase. It looks like it's enhancing, but that's actually just the hemorrhagic products that you can see on the pre. And if you do a subtraction, you can show that there's, in fact, no enhancement of this tumor. So we were able to treat this tumor with a single needle with 2 placements in under 10 minutes. Certainly you wouldn't cryoablate this patient. And if you microwave this patient, you probably would have had a lot more pain in the diaphragm because you probably overheated it because you can't measure the temperature of the tip and you have no idea where the heat's going. So, in summary, Cambridge Interventional has low artifact electrodes. I think I've shown you that. You've actually seen all the multiple size of the electrodes that are available. Certainly, everyone would agree that the ergonomics of this system is better than anything else out there. Why wouldn't it be? You've seen it. It's lightweight. It's easy. The ablations are much faster because you don't have to heat for an unspecified time because you can't measure temperature and you don't know what's going on because you just pushed a button that said on. It gives you feedback. So it's a precision device. It's a smarter ablation, and it's the most effective on the market. And thank you for your time. So we'll take some questions here.
Quick question here. So how do you assess that? What is the total amount of energy you have deposited in the entirety of the tumor? Let's suppose you're treating a 2 centimeter nodule on the lung. You obviously know the temperature at the tip of the probe, but how do you assess that you have got adequate margins and you have treated the entirety of the tumor, and how long does it take to get that?
Correct. So the question was, how do you know what the temperature is away from the tip? The tip is your probe, okay? So when you get to the maximum temperature in that spot, you pull back and then you put it lateral, and then you measure the temperature. If the temperature is 80, pull it back, measure it again, and you come out to the outer margin. If it's 80, you've killed it completely. In that particular case, I treated medially, I pulled out, and I treated laterally. So I did 2 ablations, almost like a chopstick here and a chopstick there, but with 1 electrode.
And if it's a 2 centimeter tumor, would you use a 2 centimeter active tip, or what is?
You could do 2, but you might want to pull back in tandem and do a second ablation on the proximal side, or you could use a 3. The benefit of the 3 is you use 4 grounding pads instead of 2 because there's more metal, and you can get more amps. And you have 370 watts power, so you can really blast these tumors, but you're not blasting them like microwave. Remember, RFA doesn't heat above 80, 90 degrees Celsius. Okay? So that's how you're interrogating what you've done. So.
And in terms of tumor margin assessment, it's just the ground glass halo that you assess?
Right. Now Rob can explain that really well, and I'm going to try to emulate him on this one. So the ground glass is a mixture of live and dead tissue. The inner half is dead, the outer half is live. So if you get a 2 centimeter margin of ground glass, you're probably going to be perfect. When they do it, SBRT, they only want an 8 millimeter margin when they do their planning. So if you get a 1 centimeter on that, it turned out to be metastatic melanoma, that's not coming back. I mean, that's well cooked. And the key is you only had to use one thin antenna, right? And it's a fraction of the cost of the disposable you use if you had to cryo. And the post-cryo irritation is so much more severe than it is by doing an ablation up against the pleura with an RF electrode.
All of the cases you showed were done with sedation or?
They're all done with sedation. I don't use general anesthesia for lung cases. Never have. You don't need it. You don't need it. Bupivacaine is your friend. Lidocaine is your friend. Sedation is your friend, and I play music for my patients. I'm serious. It's very healing and soothing. Any more questions? Go ahead. When do I not do RF ablation? If I have a large chest wall mass close to the skin, I'll use cryo. If I have a medially placed kidney tumor inferior that's close to the ureter, I don't like to do perfusion with heat and put in a catheter because that patient has to go to the OR for the C-arm to put that in before the case. What I will do is I'll have them put in a double J nephroureteral stent in their office or at another time, and the patient will come back a week later and I'll do the ablation with cryo with the stent in place, and that protects the ureter, and then they remove it 2 weeks later. So cryo is great for certain things. RFA is greater for more things. Microwave has its moment, but I would say that if I was starting out in a practice and my administrator said, you can only buy one system, if you didn't buy this system, you would be doing yourself a disservice.
Quick question, Damien. The data for local tumor control in the lung, RF, came out in 2015 in chest. Was a little bit on the lower side compared to microwave and cryoablation that came out more recently. You think it's because of the lower power we deposit
Yes,
in these cases?
yes. And all of us who cut our teeth on lung ablation with RF, we had an impedance problem. And you could never measure temperatures that were in the toxic range because it would shut off so quickly. So you had no idea what you were doing. So that's why we did the triple electrode cool tip when I ran that NSF and that trial, multi-center trial, because you could actually get more power in with the 3 tines. But people were afraid of doing that because that's 3 pokes, you're going to have a higher pneumothorax rate. But with a single needle, you don't need it now. So it would be interesting if somebody wanted to do a trial comparing, cryo and high power RFA. Do a 3-arm, you could do it with microwave too. And I'm telling you, I haven't put a chest tube in an entire year, and I did 40 primary lungs last year, and I didn't put a chest tube in.
The introducer is 16 gauge or 15?
17 gauge. Yeah, and what I do is, in the extrapleural space, I inject lots of lidocaine and bupivacaine. And again, it paralyzes the musculature for a good 12 hours. And when you pull your device out, all that fluid under pressure kind of fills the hole. So pneumothorax is like a thing of the past. I quote my patients as about a 3% chance you'll need a chest tube. Most people are saying 50-50. It's like, you got to be kidding me, Learn a new technique, right? So. Bone? Bone is great. The problem with bone is if it's not destroyed, you got to drill there, But I had a guy who had a tumor in his humerus, and I was able to drill, and it was a long tumor, and I was able to get an RF electrode all the way down the marrow space and heat it and pull back and treat it with a single RF electrode. So that was kind of cool.
Would you use it for palliative care?
That was palliative, yeah, for sure. But no, it works really well in bone. And I actually ran a multi-center trial in bone for palliation, and that was a positive study, and that was published before the cryo trials, you know, and people forget about that trial, but it works. It works in bone. So. All right, thank you for your attention. Have a good weekend, everybody.